All right, everyone, good morning or afternoon if you're on East Coast time. I am a little backwards today. So today we are going to be talking about 3PD, Pppd, Pppd, let's call it anything you want to call it, persistent postural perceptual dizziness. We're going to go through the diagnostic criteria. This is a really popular one. People ask about this one a lot. So we're going through the diagnostic criteria, kind of what it feels like, the symptoms, what it is, what it isn't, and what you need to actually be diagnosed with 3PD. Remember that this is not medical advice. This is never medical advice. This advice is to be educational about your vestibular system. If you think you might have this problem and you haven't been diagnosed, or you think you've been improperly diagnosed, I cannot answer those questions. All of those questions need to be directed to your doctor. All right, so let's first talk about what 3PD is. So in general, 3PD is the persistent sensation of rocking, swaying, basically non-spinning vertigo. So that's like an internal feeling of like this, or like you're moving somehow, lasting greater than 3 months. So if you've been dealing with this for a couple of weeks, it's probably not 3PD. It does have to be on most days, so for at least half of the days. So they say for every 30 days that goes by of your at least 90 days, it has to be present for at least 15 of the days. So it has to be present at least half of the time. It can wax and wane, meaning it kind of comes and goes depending on the time, what you might be doing, etc. 3PD is worse when you're standing up usually, and better if you're still, and best usually in a supine position, which is ironic because a lot of people really hate lying flat. A lot of people think if they lie flat, then they might give themselves BPPV, which is benign paroxysmal positional vertigo, very different. But you cannot give yourself BPPV. It's something that's mechanical. It can just happen. If that is a thing for you, you can't lie flat, that's something you should ask your physical therapist. Someone saying right now they've been dealing with this for a while and their second vestibular appointment is today, you're really nervous, you're going to do great. Seriously, VRT is a game changer for so many people, especially when it comes to positional stuff and kind of relearning how to move in a safe environment. I would also recommend that if you're dealing with 3PD, it's a little plug, but also only because it's actually helpful, is returning to exercise in a safe way. Vestibular Group Fit is the only program that helps you do that with a vestibular disorder. If you have any questions about that, you can absolutely either DM me, put your question here, whatever you'd like, and we can go from there. So let's kind of read through the diagnostic criteria for 3PD. You do have to meet all 5 of them, and you're going to see me reading because I'm going to read these word for word because I think it's important that the wording does not get confused and I don't trip up on any of the wording. So the diagnostic criteria for persistent postural perceptual dizziness, you must meet all 5, and they're A through E. So let's start with this. So A is 1 or more symptoms of dizziness, unsteadiness, or non-spinning vertigo present on most days for 3 months or more. Symptoms last for prolonged periods, so hours long at a time, but may wax and wane in severity. And symptoms need to be present need not be present continuously throughout the entire day. So most of the day, but not the entire day. B, persistent symptoms occur without specific provocation but are exacerbated by 3 factors: being upright, active or passive motion without regard to direction, position, and exposure to moving visual stimuli or visual patterns. So things like visual vertigo are in 3PD. C, the disorder is precipitated by conditions that cause vertigo, unsteadiness, dizziness, or problems with balance, including acute, episodic, or chronic vestibular syndromes, other neurological or medical illnesses, or psychological distress. When the precipitant is an acute or episodic condition, symptoms settle into a pattern of criterion A, as the precipitant or other issue resolves, they may occur intermittently at first and then consolidate into a persistent course. When the precipitant or other confounding factor is a chronic syndrome, symptoms may develop slowly at first and worsen gradually. D is symptoms cause significant distress or functional impairment. And E is that symptoms are not better accounted for by other disease or disorder. So I think it's really important to read through these because 3PD gets a lot of hype, but a lot of times is not actually 3PD. So the most important things that I think of when I'm thinking if a patient actually has 3PD or not is, do they have an underlying or confounding factor? So 3A and B say that the disorder is precipitated by conditions that cause vertigo. So you have to also have another condition. You can't just have 3PD. Like if you go to the doctor and your doctor's like, oh, you're dizzy all the time, you have 3PD. That's possible, but you also have to have a secondary diagnosis. You cannot just have 3PD. You have to have vestibular migraine, neuritis, BPPV, panic attack, other medical disorder, neurological disorder. Basically, it has to be on top of something else. I cannot stress this enough. You cannot have just 3PD. This is a diagnosis that gets thrown around a lot, especially since the criteria are pretty new. But again, this is not a diagnosis that stands alone. This is a diagnosis that goes secondary to something else. And it's really, really important to remember that. And that's also why I think it's so important that I list all of these specific criteria word for word. If you want to read the study, it is I think it's open access. It's by Jeffrey Staub and other people. There's like 8 authors on here. It's a lot. The first person is Jeffrey Staub at Mayo, and it's a Barony Society definition. So again, I can link this if anyone's interested, but it is something that's very specific. Someone say it's not too difficult to prove that you have 3PD. No, it's not difficult to prove at all. Like, I don't think that people are arguing about whether or not you have it, but most of my argument with other people, not an argument, both my statements, I would say, are that you probably have something causing the 3PD. It's not just 3PD. OCD, cause for vestibular. So OCD is not a cause for vestibular migraine. It can be with vestibular migraine. People with other neurological factors are more likely to have things like migraine and 3PD, vestibular disorders. So that's very possible. I will definitely get into the treatment of 3PD in a second. So remember that 3PD is worse with standing up, movement, active motion, or passive motion, and exposure to rich, stimulating environments. So the difference between, someone asked this very specific question, and the difference between MDDS and 3PD, big difference, is that 3PD, if you're in a car moving, you'll feel worse. MDDS, when you're in the car and moving, or train, boat, whatever, when you're in it, you'll feel better, and when you stop, you'll feel worse. So if you stop and you feel worse, it could be 3PD or MDDS, but it's important to remember that if you feel better in the car, it's MDDS. If you feel worse in the car, it's probably more 3PD or other vestibular symptom. People who have a bigger preponderance towards being anxious or towards panic, towards thinking, like overthinking their dizziness, those are the people who are more likely to get 3PD. There are other there are people in the vestibular world who have vestibular conditions, but kind of don't think twice about them, and they're not better or worse than the people who do think about them. Often it's just a different way of thinking about dizziness. The people who tend to ignore and just move on are the people who are usually less likely to get a 3PD diagnosis. And that kind of leads me into the first of the treatments that we're going to talk about, which is CBT and ACT, so cognitive behavioral therapy and acceptance and commitment therapy. Those two things are really, really important, and I plug this human literally every single week. If you do not follow her yet, which I know a lot of you don't, and you should, like, I'm my number one recommendation, if you do nothing else today, is to go follow Rooted Behavioral Education on Instagram, Dr. Kostalnik. She has a whole course about all of these things that might make you nervous in the vestibular world. And it's literally just go follow her. It will change your life. You can even close me out right now and come back to go follow her. She's at Rooted Behavioral Education. I plug her every single week. She's excellent. Please go follow her, especially if you have a lot of anxiety surrounding your dizziness and you would like to take care of that. Her course is great. So again, it's a secondary condition. In case you're just joining us now, 3PD is not a standalone condition. It is a secondary condition. You need to have another diagnosis. Even if you're still working on what that diagnosis may be, make sure your doctor is aware that you do need another diagnosis, okay? Most people in the questions that they asked me, everyone had very specific questions, but the general vicinity of the question was, how do you get better? How do we treat this? Does X work? Does Y work? So we're going to go through the ways that you treat 3PD. The big ones are physical therapy, so VRT, medication, so that can be any form of medical treatment, whether it's supplements and vitamins or it's something else. Medication can be on the table and other medical treatments. Cognitive behavioral therapy and acceptance and commitment therapy, so kind of getting on the mental side of it all, definitely going to be helpful. Then you're going to need vestibular rehab and then exercise. And honestly, as a person who does vestibular rehab for a living, like I think everyone should do vestibular rehab, for people with 3PD, getting into an exercise program I have found is more important because it helps so much with like returning to a functional schedule than anything else. I found that is just as effective, if not more effective than VRT. There are studies on this. It is really, really important to do. So let's first start with medication. I know we talked a little bit about the behavioral side of this, but I am not a specialist in behavioral things. That's why I told you to go follow Dr. Kostalnik. That's why she's so great. So let's first talk about medication. So it's very dependent on you. Again, you can see a psychiatrist, your GP, neurologist, ENT, whoever. They can all prescribe for this. But basically, medication that is specifically for this, SSRIs and SNRIs. So those are typically like antidepressants and anti-anxiety medications. They help increase the amount of serotonin in your brain for longer periods of time, and those are really helpful because a lot of brain issues in general have to do with not enough serotonin. So I'm not a neurologist. You guys know this by now, but I do know that much. So if you feel like a medication might help you, there's no shame in taking a medication. A lot of people are often really nervous about whether or not they should take a medication. But I think it's important if you are prescribed one and you can't just, you're not feeling like you're able to handle your anxiety, at least short term, this can be really, really helpful. I see a lot of people asking about all their negative testing and how they get a diagnosis. We can cover that. Let me just write myself a note. What you need to know, the basis though, is that most vestibular conditions don't show up on testing, so you're not alone there. So yeah, medications that are for anti-anxiety and antidepressive medications can really, really help with 3PD. Making sure you get on the right one is really important. If you have, like, if you're nervous about taking them, everyone has a different reaction to it. Everyone needs different medication. If you have a skilled psychiatrist or neurologist that you trust and they have prescribed you this and nothing else is working, like exercise isn't working for you, which you absolutely can try because exercise and antidepressants are compared all the time to each other. Absolutely a good idea, especially if your copay for your medication is high. You could just join Group Fit and it would probably be the same price. So that's definitely an option. Exercise can really help. If you find it doesn't help, take the medication if it's been prescribed to you. Talk to your doctor if you're feeling nervous about it. It's always, again, this is not medical advice. This is something that you should have a conversation with your doctor about. So Next, after we've talked about medications for 3PD, let's talk about medical treatment for, let's talk about medical treatment for your underlying condition. So if you have 3PD, again, you need an underlying condition. So that is vestibular neuritis, migraine, BPPV, Meniere's disease, panic attacks, panic disorders. Literally anything can be the underlying disorder, which makes this kind of frustrating to try and diagnose. But if you do know your underlying disorder, having someone who can help treat that is really important. So again, that is a neurotologist, ENT, neurologist, vestibular therapist. All those people can help control that underlying condition as long as you know kind of what it is. So treating that with medication, with other medical treatments, with vitamins, supplements, exercise is going to be really, really helpful. The next we're going to talk about is, we already touched on CBT, so let's go to VRT. So finding a safe place where you feel okay moving and feel like, okay, I know now how I can move my head, how I can bend over, how to lay flat. All of those things are going to be really, really helpful for treating your 3PD because, again, it is so much of an anxiety response to your vestibular disorder. So if you feel like you're now able to move more easily, you're able to get back into your functional activities, then the 3PD will start to dissipate. The more like presence in your brain that you give 3PD and the more you focus on the way that the dizziness feels, the more 3PD symptoms you're going to feel and the more anxiety you're going to feel. So it can be really, really helpful to try to put your symptoms in a proverbial box and then worry for 15 minutes a day. Put that box on a shelf, take it down during your worry time, and then put it back up there. And that's something that a psychologist and a psychiatrist can really help you with. That is just like the tip of the iceberg of how this works. I am not, again, a psychologist of any form. I'm a physical therapist. So if you want help with that, again, rooted behavioral education or your local psychologist, super helpful for you. VRT, again, can be so helpful in creating that space for you to try movements that are scary and strengthen your vestibular system. So if you have an underlying vestibular condition, you probably need to strengthen your vestibular symptoms. Sorry, someone's making coffee in the other room. So you're going to need to strengthen your vestibular system overall in order to decrease your dizziness overall. It's sort of like I like to compare an ACL injury. Everyone's known someone who's torn their ACL, right? And they have, like, you could probably notice their legs are a different size after surgery because of all the deconditioning. So your quad muscle, the muscle on top of your thigh, if you're just looking down at your leg right now, that muscle gets really, really weak when people have an ACL repair. And just for the rest of their lives, they're going to have to do probably a little more quad exercising on that side than the average person. And that's okay, and that's normal, and it's the exact same thing with your vestibular system. You need to do extra vestibular exercises probably forever, even if you're in VRT or not in VRT, to strengthen that system and strengthen the connection between your vestibular system and your brain. It is of utmost importance to keep that system strong so that you've raised your threshold to having vestibular attacks, raise your threshold to feeling dizzy throughout your day, raise your threshold to everything. That's sort of the key to success, and that's why VRT is so important and why a vestibular therapist should absolutely be on your team. The last part of 3PD treatment that I want to touch on quickly is exercise. So as you guys all know, I have my group exercise program, Vestibular Group Fit. This is not necessarily a plug for Vestibular Group Fit. This is literally how you treat 3PD. So if you have 3PD and you're not exercising, please DM me after this and let me know if you would like some help with that, because it's a very affordable program. It is super comprehensive. It has everything you would want to know about your vestibular system in there, how to strengthen it, how to deal with visual vertigo, navigating social situations, etc. People are making huge gains. Like a couple weeks in, people are going to the grocery store again, driving their kids to school again, doing all these amazing things. And everyone's happy because they're in a little bit better shape. So all good things there. We exercise together 3 days a week, both live, and then you can do some on your own workouts. I'm always looking to improve it, so I'm always looking for feedback too. So that is my plug for that. But exercise in general, you need to be doing for for 3PD. The first time I ever heard of 3PD, I was at a conference. I was still in PT school, and I was like, oh, this kind of seems interesting. I'm kind of interested in vestibular disorders. This was way before any of this community came to be. This is years ago. So I went, and I remember the biggest takeaway I got from that lecture was literally that the PT said, okay, you are not functioning like you used to. You're a pretty active person. How are we going to get you back to your routine? And literally, she's like, more than anything else, being able to get my patient back to exercising every day helped more than anything. It helped with routine. It helped with community. It helped strengthen his vestibular system without anything else, like without intentionally strengthening, right? Like it helps with everything. It helps increase your endorphins. It helps decrease inflammation, which inflammation is a huge thing. And it's actually what we're talking about in our next module in vestibular group fit is inflammation and exercise, endorphins, and how that all helps with both your brain health, your body health, and your vestibular health. So exercising is a huge one. It gets you back to feeling like yourself again. Again, vestibular group fit is the key to that, but you don't have to join if you don't feel like that's right for you. So if you feel like all I can do is walk, just walk. Like walk at a brisk pace. Don't walk slowly and lollygag. Kind of really get your arms moving, get your body moving. All of those things are going to be really, really important for you because that is how you reduce 3PD. And I know it sounds crazy, like I just need to exercise, but it's not the only thing, but it is one of the biggest things. So if you are not already, please exercise for 3PD. It's really helpful. I know this is the most popular topic on my whole entire account. I see the insights, I see the analytics, I see what you guys ask me. So if you are still having questions about this, obviously go ahead and rewatch this, but please start exercising. And you're always welcome to join Group Fit. I'm not going to force you to do anything, but that is has been really successful for a lot of people. Okay, I'm going to scroll back up these comments and see if we can answer any general questions. Again, I cannot give medical advice, but let's see. So first, what's the difference between VM and 3PD? So vestibular, I just did a post on this last Tuesday, I think. So please scroll back and look at that later. But VM is a neurological condition. It is a dysfunction of your brain. Basically, it's a neurological disease. You have this nerve. It's called your trigeminal nerve. It looks like this. It's the fifth of your cranial nerves, and it goes up, out, and down. And that massive nerve is what causes all that pain from migraine for a lot of people. It has a synapse or like a connection to the trigeminal cervical complex. So that's this nerve plus your neck complex, which then triangulates with your vestibular system and makes you dizzy if you have vestibular migraine for some people. So that is a vestibular migraine. That's like the simplest. And then 3PD is a secondary condition. And it is the chronic symptoms. You can have chronic vestibular migraine that you can't really tell the difference between one attack to another. I do understand that. I'm not saying that that's not a thing, but I do want to make it clear that there is a difference between 3PD and vestibular migraine. I apologize for the drilling sounds. There's a lot of construction going on in my mom's house right now. So that's the difference between those. Again, if you want a more comprehensive answer, please scroll back just a couple days on my Instagram. I did a huge post on this. Is recovery possible or is it permanent? 3PD is absolutely not a permanent condition. It is absolutely recoverable. I have seen patients do it. I have quite a few patients who this has happened for. It's in the middle of happening right now for one of my patients. She's almost good to go, and I'm so excited. I don't even know if she knows it, but I know it. Like, it's almost gone. There's just like some head pressure left, which is technically not 3PD, which is a huge deal. So it definitely is treatable. Again, if you need medication, take the medication. There's no shame in taking medication. If you need VRT because you're scared of like a certain movement, like laying down or moving your head back and forth too fast, please go get help with that. And then please, please, please exercise, whether it's vestibular group fit, whether it's you walking briskly, whether it's you doing yoga every day and getting your heart rate up. Your heart rate does need to be in aerobic capacity. It does need to be helping you get into a routine, but please, please, please exercise. And then why are my eyes so affected with 3PD? Someone asked about looking into the mirror. But why your eyes so affected. So that's because you have visual symptoms. Visual vertigo in 3PD is really, really common. So again, when we listed at the very beginning of this, it's exacerbated by 3 factors, right? The third factor was visual moving stimuli and complex patterns. So treating your visual vertigo either with your PT, or if you've already done it with a PT, you kind of know how. You can do it through vestibular fit as well. I have a whole thing on how to treat visual vertigo. I always call it vestibular vertigo, which obviously visual vertigo. So to treat your visual vertigo, you need to slowly expose your brain and reweight your symptoms. So you have to reweight your proprioception versus your vision versus your vestibular for balance. And reweighting means you need to depend on each one accurately. When you have a vestibular dysfunction, you're not accurately depending on your vestibular system and using it in the way that you should. And that module really goes through all of that. And again, that's in vestibular group fit. I know it seems like just it seems like just a fitness program, but really it is like a holistic, well-rounded program for literally everything. I gave someone joined the other day and was like, oh my God, you're not charging enough for this. So I'm serious, it is very affordable, and you can go ahead and give that a shot if you would like. I'm offering 1 free week right now if you're watching this, so DM me if you'd like that. All of my tests have been negative. How do I know what the underlying problem is? So if all of your tests are negative, the thing that I see most common with negative tests, if you actually have a vestibular disorder, is vestibular migraine. You will have a negative ECOG, VNG, MRI, CT, X-ray, a negative blood test, literally negative you name a test, it could probably be negative if you have vestibular migraine and you don't need head pain. So that's why it's so difficult to diagnose sometimes. There are diagnostic criteria for that as well. They can be found on my website or with a quick Google search. But if you're having all negative testing, the underlying condition could be a multitude of different things. It could be Meniere's disease. Again, you just need to fit the diagnostic criteria, and you need a doctor who's skilled enough to know to even look up the diagnostic criteria. Your PT cannot give you a technical medical diagnosis because it is not in our wheelhouse. It's not our job. I know what all of them are, and I have almost all the criteria memorized just because what I do for a job, but that doesn't mean I give the people the diagnosis. I tell their doctor, hey, this patient might have this, and that's way different. It's hard because neurologists just slap on a VM label when they're unsure and dismiss the 3PD. Yeah, that is tough. And VM, I do feel like gets thrown around a lot, especially when you're not sure. Like a lot of people with POTS and stuff like that get diagnosed with VM, but they don't have VM, they have POTS, which makes it even tougher. But if you think you have 3PD, you don't necessarily, unless it's causing a lot of anxiety, you don't necessarily need the help of your medical doctor to treat it. It can be treated in VRT. Someone asked if you can use VRT to control your vestibular migraine. The answer is yes and no. So if you want to control your vestibular migraine, you need to change some lifestyle things, find some dietary triggers, be sure you're hydrated, kind of calm down everything so that your threshold isn't being hit all the time. So if you haven't heard of the threshold theory yet, which you probably have, if you have migraine, think about it like this, like you have a list of controllable triggers, a list of uncontrollable triggers, and then the migraine zone. So obviously you cannot control your uncontrollable triggers. So that's like if you have lots of kids running around, you might not have slept well last night, the weather's changing, those are all uncontrollable triggers. The controllable triggers are things that you can do. You can exercise every day, you can stay hydrated, you can mostly control what you eat within reason, mostly. You can make sure you're doing breathing and relaxation techniques every day. All of those things that you can control, those can help both raise your threshold and keep you out of your threshold. So if you want to you can use all of those things. Medication can help. So yes, you can get off medication for vestibular migraine and use just lifestyle changes and modifications to control VM. That's completely possible, but I wouldn't say just VRT can control your VM. VRT's intention is to treat the symptoms between the attacks. It is not meant to treat your attacks, and it's not meant to treat the neurological disorder that you have. It is not the same. I want to be very clear about that. Okay, let's see. So you will talk to someone's doctor if you're working with someone. Yeah, so if I have a patient whose doctor like really isn't sure and they want me to talk to their doctor, then and I have permission to share medical things like through a HIPAA paperwork and etc. Yes, I absolutely talk to people's doctors all the time. I fax all of my patients' evaluations to their doctors, their progress notes, their follow-ups, whatever it is. I talk to people's doctors all the time. I don't know why more people don't do it. I'm not tearing people down here, we're bringing people up. So absolutely, I talk to everyone's doctors all the time. At least they have all the information that we're doing in VRT, whether or not they respond, that's on them. But yeah, I always talk to my patients' medical providers, and I do require most of my patients to get a prescription just so that their medical provider is aware, even though they don't technically need one. It's usually pretty easy to get. It hasn't been a problem yet. All right, what other questions do you guys have about 3PD? You can put them at the bottom right now, and I will go ahead and answer a few more. I have some extra time. Go ahead, and I'll scroll back up and see if there's more too. Can it make you feel like you're falling backwards when you're laying down? Yeah, a lot of people hate laying flat because it makes them feel like they're falling backwards, or like they're going to fall through the bed, but that's definitely something that you can help with VRT. All right. All right, team, if you have no more questions, I will go. I will use my time elsewhere. I hope all of you have enjoyed this. I hope that this has kind of cleared some stuff up about 3PD and it's been helpful. One last chance for questions right now as I finish up. Again, this is not medical advice. This is never medical advice. Nothing I say here should be used as your medical treatment. You should always ask your doctor, your PT, your healthcare team about what's right for you. So glad you're here too. All right, friends, I'll talk to you soon. Bye.